Good afternoon, everyone. It is 12 o'clock on the nose, so we will get started. Welcome to the last of our 2022-2023 Fairbanks Lecture Series in Clinical Ethics. My name is Brian Leland. I am the director of the Fairbanks Center for Medical Ethics. A pleasure to welcome you all here, both in person and anyone joining us remotely. Please use, let me find it. There we go. The code that you see on the screen and text that to receive your CME or CE credit for today's lecture. And then of note, certificates are being sent out approximately 30 days after the lecture. So you can bother us day 31 if you've not received it. A couple preliminaries before we get started. As I mentioned, we do have people joining us remotely, and this will be recorded. And if you want to rewatch it, or someone that you know was not able to attend in person or virtually wants to do so, it'll be available on our website, which is fairbankscenter.org, usually within about a week. And we would certainly encourage you to send the information to colleagues. And then we also have a Q&A box available if you want to post questions, and we encourage you to do so. However, with rare exception, we will not interrupt the presentation in the middle to ask for those to be addressed, but rather do so at the end of the presentation. Dr. Rouse and Ms. Martin have no conflicts of interest to disclose at this time, and it is my pleasure to introduce the two of them now. Dr. Carolyn Rouse joined the IU Maternal-Fetal Medicine Division in September of 2017. She is Indiana native and is a graduate from the IU School of Medicine class of 2010. Whoop, whoop. Yeah, I whoop whooped. That's what happened. She completed her OBGYN residency at the University of Washington School of Medicine, followed then by her MFM Fellowship at Brigham and Women's Hospital in Boston. And then she is currently the medical director of labor and delivery and co-director of the OB intensive care unit. Lisa Martin, who is also with us today, is originally from Indianapolis, Indiana, another native Hoosier, and has been serving as the chief compliance officer to IU Health since 2013. Prior to serving in various in-house counsel roles for hospitals, she received her law degree from the University of Virginia and spent nearly 10 years with firms in California and Tennessee, providing trial defense for drug and device manufacturers in product liability cases. We are ecstatic to have them join us today to provide for us an update on the Indiana abortion law, current status, and planned implementation. So without further ado, please welcome, I don't know who's going first, to the stage.
All right, thank you guys for joining again. I'm Lisa Martin. A little bit more housekeeping. If you are an attorney that is present or on the phone, please send your Indiana bar number to me afterwards. My email is on the screen, and I will make sure that I submit that for CLE credit for any attorney who's paying attention. Okay, so we have got an hour, and our goal is that we reserve 15 minutes at the end for questions. So we're going to cover a lot of material very quick. 3 parts. First part, we're going to talk about the law in Indiana, what's going on. Second part, we're going to talk about what we've done at IU Health and at the School of Medicine in terms of preparing for and implementing portions of the law. And then finally, we're going to talk about some weird things that have happened since then, what we're seeing out there, both in Indiana and in other states, on how these abortion bans are interacting with other rules and other sort of social situations that are going on. So when I put together these slides, it's been a year. I mean, Dobbs wasn't even a year ago. So to set the stage, pre-Dobbs, as most everyone probably knows, is in the United States, the Supreme Court had recognized the right for a woman to get an abortion pre-viability, generally considered to be about 22 weeks after your last menstrual period. Yeah, fair enough. And the state couldn't put any undue burden on that. So then in June of last year, the Supreme Court said, you know what, we disagree with that. And that is not a right that is guaranteed by the Constitution. And we are returning the power to the states. And states can now decide on a state-by-state basis whether or not to allow abortion. Indiana quickly became, as a pledge of Governor Holcomb, quickly became the first state to pass legislation. I'm going to call it an abortion ban. We'll talk about it. There are few exceptions to it, so it's not a total ban. But Indiana became the first state to pass an abortion ban in August. We'll talk about the work that we did in between August and September. The ban took effect September 15th. Prior to that, a couple different court cases were filed challenging the constitutionality of that ban. We'll talk a little bit about both of those. In the first case, they said the liberty interest in the Indiana Constitution protects the right to abortion. At a very preliminary level, the trial court agreed, and they enjoined the enforcement of the abortion ban in 5 counties in the state of Indiana. That took place in September. The second case was a challenge saying that the abortion ban puts impermissible restrictions on my right to practice religion guaranteed by Indiana statute known as the Religious Freedom Restoration Act. And again, the court, very preliminary basis, agreed with that, and a separate injunction was issued in December, and we'll talk about the interplay between both of those. So, current state of the law. There is a law, it can't be enforced. Okay, so what does the law say? And this is a busy slide. You guys can read it. I'm going to talk about it very generally. So, prohibits abortion except in 3 cases. Rape, incest, again, there's a limitation on that in terms of timing, 12 weeks after the last menstrual period. Reasonable medical judgment, there's a diagnosis of lethal fetal anomaly. Again, there's a time limitation on that of 22 weeks. And then no time limitation is on the reasonable judgment of the physician that the pregnancy presents a serious health risk. Now, we're going to talk about some of these definitions as we go through, because the definitions cause problems in how we interpret and apply this law. When you apply any one of these exceptions, a physician, Dr. Rouse, has to enter a certification that says, yes, it's a serious health risk. So you're putting your medical judgment on the line to say that. Another big change is that prior to this law, Whole Woman's Health, Planned Parenthood, other abortion clinics could provide abortions. After this law, abortions could only be provided in hospitals or in hospital-owned ambulatory surgery centers. So the location where these limited exceptions could occur was pretty heavily curtailed. So let's talk about a few of those definitions. One of the main ones that was a problem to us, and Dr. Rouse and I both gave input on how we think abortion should probably be defined going forward, is the definition of abortion itself, or rather the lack of definition. As all the medical professionals here know, you use abortion to refer both to what I would consider a miscarriage and what the public would consider an abortion. So when you're trying to parse out ectopic pregnancies or other situations that the population at large wouldn't consider abortions, but in fact fall within that definition, we get into some problems. So one of our first things that we ran into in terms of termination of pregnancy report and everything that came up is, what's our obligation in this odd class of procedures where we know we have to perform an abortion and it's not commonly thought of as that? It's probably bad terminology, but you can see we talked to the State Department of Health on that, and they gave us guidance around whether or not you need to file that termination of pregnancy report. You can see the list there: missed miscarriage, septic, inevitable, ectopic, molar, and any where the fetus has died in utero, but that would be outside the definition. So that is a little bit of interpretation that the Department of Health gave us in addition to the definition of abortion. Fortunately, they put that in writing in guidance, which is helpful to us. Serious health risk. This is another one that we can talk about a little and we get questions on as you look forward and try and think about what qualifies as a serious health risk. What degree of preeclampsia needs to be present before you can say an abortion is appropriate. That's going to sit within the reasonable medical judgment of the physician to make that determination and to certify that determination. Again, you're putting both potential criminal sanctions and your license on the line if you get that wrong. And then finally, lethal fetal anomaly. This is another term that's not a legal term. You can see the definition here again. Fetal condition diagnosed, reasonable certainty to result in death within 3 months. This is, I mean, I don't assume that physicians are perfect prognosticators. So again, you guys are going to be doing your best as you try and make a determination about what a lethal fetal anomaly is. So those are 3 of the big sort of hiccups in this law, and one of the spaces where there's some ambiguity, and Dr. Rouse and I, from time to time, give some interpretation. Let's talk a little bit about the 2 court cases that came in. So the first one, again, it talks about that liberty interest in the Constitution. And if you guys are confused and you're like, I don't understand that, the highest court in the land said that there's no constitutional right. The principles of federalism provide that we as a state get to have our own constitution, and we get to interpret that constitution independent of what the United States Supreme Court does. So Planned Parenthood and some other providers came forward and they said, you're violating the liberty interest in the Indiana Constitution. Very broad, right? You can see it in there. You've got the right to life, liberty, and the pursuit of happiness. And then there's a large debate over what that means. The trial court in the Monroe County looked at prior court rulings and determined that, in fact, I'm gonna back up a little bit. This is at the preliminary injunction stage, so don't get too excited. This is sort of an initial determination on whether or not the plaintiffs are likely to win. So we're not ruling on the whole underlying court case. We're ruling on whether or not this law is most likely unconstitutional and would cause enough harm that we should prevent it from going into effect. So that's what the judge ruled on here. They said it's likely that the plaintiffs will prevail, that there is a constitutional interest in a woman deciding whether to carry a pregnancy to term. This was immediately appealed to the Indiana State Appellate Court. The defendants, the Attorney General's office, filed to have that pushed immediately to the Indiana State Supreme Court. Oral argument on the case occurred in January. And you'll see in the resources at the end, I put the link to that oral argument. Everybody can get on and listen to it if they want. It is fascinating to listen to because there's some very philosophical questions around what are the limits of individual liberty, right? Does the person have a right to freely take dangerous drugs, right? So things that aren't abortion, but thinking about if we allow this, what is the natural limit that we would put on that liberty interest? So we are waiting for the ruling in this. But even if they came back and they said, Supreme Court says, you know what, trial court, we disagree with you. We think you are not likely to prevail on the merits, and we are putting the law back into effect. It would still not be in effect because a separate court case has also enjoined the law. And in this court case is very interesting. You have a collection of different religions and people who practice that religion who came forward and said, you know, my religion does not believe that life begins at birth. And my religion believes that I actually have an obligation to obtain an abortion when there is a threat to my health. And that obligation is larger than what the Indiana statute allows. And because of that, you are violating the statute known as RFRA, the Religious Freedom of Restoration Act, which says you can't put an undue limitation on my religion, the practice of my religion, without a compelling interest. This one was in Marion County, and the Superior Court agreed and said they do have an interest. The plaintiffs in this case had actually changed their practices. They were either having no sex or less sex, so to avoid pregnancy. So they said, hey, they have taken a change in action. And then the state said, but we have a compelling interest in the preservation of life. And we believe that life begins when the egg is fertilized. And the court said, no, that is a theological, philosophical determination, and you can't have that as your compelling state interest. So this case is sitting at the Indiana Court of Appeals. Oral argument's been fully briefed, and they're waiting to have oral argument in this case. So those are our 2 separate cases. Bottom line, the law is not in effect. one of these cases gets decided, the other one's still present. It is a very fluid situation, and we will, Carolyn or Dr. Rouse is going to come up and talk about what we've done, where to find resources, and we will update those resources as soon as anything happens on these cases.
Okay, so what happened leading up to and including the abortion ban? So after Dobbs, everybody in my immediate sphere was obviously freaking out before and after. You know, I think that people who work in the reproductive health space had been concerned about something like this happening for a long period of time. And then when it finally did happen, the reality sank in that we are going to have to learn how to work in a world where there is most likely going to be an abortion ban, because it was no secret that the legislature of the state of Indiana was interested in further restricting reproductive choice from where we had already been. So within a month or so after Dobbs, it became clear more widely that the implications of an abortion ban were going to not just affect OBGYN providers and their patient. This is a wide-ranging policy that is going to affect essentially every aspect of anything that has to do with healthcare. So Dr. Ingram headed up what became known as the abortion implementation team in order to assess and make plans for how this law would affect every aspect of IU health, essentially. So the sort of most obvious, of course, would be the clinical. So how will an abortion ban affect our clinical practice? How are we going to implement this law every day in our clinic and our ORs? How are we going to be, taking this from the courtroom into our daily practice? It also included things like operations, planning, GME. How is this going to affect our learners? Abortion care is part of ACGME requirements. I'll get into that in the next slide. For OBGYN residents, it is part of the training. So how are we going to appropriately educate our residents in the setting of this abortion ban? Government affairs, obviously super important. Tori Castor has just been amazing throughout this whole thing in terms of interfacing with the legislators during the special session that happened over the summer, trying to inform as best we can about the implications of this law. And, you know, as Lisa was saying earlier, just the very definition of abortion was super problematic. The initial definition of abortion was anything that any procedure that doesn't result in removal of a dead fetus or a live birth. So, you know, ectopic pregnancy, how are you going to define that? Are we going to have to be reporting that to the state as an abortion procedure? So those types of discussions had at a very high level were incredibly important to mitigating the damage that would result from such a law. Patient quality and safety, obviously, safety officer, there is a long history of threats of violence and actual violence against people who provide abortion care and their facilities. And so that was something obviously that IU Health wanted to be aware of and in front of. Finance, how is this going to affect us? Financially, you know, thinking about things like NICU utilization. If there is an abortion ban in place, there are going to be more babies born. There are going to be more babies born requiring higher level care. That is, you know, both planning and financial and all of that. And how do we predict the increase in births that are anticipated and NICU costs and all of that kind of stuff? Public information, also important. How do we message what IU Health is able to do and the care that we're able to provide? Ethics, obviously super important as well. In my opinion, this law is very unethical, but I'm just me. And so when there are complicated questions that come up, we needed to have you know, a team that helps us to answer those specific questions that come up in those circumstances. Legal, obviously, with Lisa, very important in helping to interpret the law, and then also helping us to know how we as abortion providers are going to be protected by our employer going forward in this really restrictive and scary setting. And then HR, of course. One thing, I'll go back to ethics, is we knew that even after we came up with clinical workflows and plans and messaging and all of this stuff, that there were going to be questions that would arise that required a really nuanced sort of evaluation and interpretation and answers to providers who are on the ground, who are just trying to do their best for their patients. And we knew that these could come up at any time, really. So as part of this implementation team, we formed a reproductive health rapid response team, which is comprised of a clinical specialist, a legal specialist, and an ethics specialist. There's a slide later that shows how to get a hold of that person, but essentially we're available 24/7. If there's a question that comes up related to abortion care within IU Health, someone is available to help answer those questions. Oh yeah, here it is. So IU Health also made these resources available through the portal. This is Lisa showing us exactly how to get to it. And so this has information for providers. There's a whole list of things like how to, like documentation and FAQs, which we worked really hard on. So how does this, what does this mean for me? So trying to make an easily accessible resource for people having questions within the rapid response team for backup in the event that the question couldn't be answered. Back a little bit to residency training. This is obviously incredibly important. It's incredibly important to me. I'm one of the assistant program directors for the OBGYN residency. And so this was a primary area of concern when the abortion ban was going into effect. So what is the IU School of Medicine going to do to get required training for its residents? These are the ACGME program requirements. So we are required to provide didactic activities and clinical experience in comprehensive family planning. That means abortion services and contraception. Programs must provide clinical experience or access to clinical experience if abortion provision of abortion as part of the planned curriculum. And if you live in a place where that is not possible, you have to figure out how to make it possible for your residents. And so our program specifically investigated and has a plan for, should the ban come back, having our residents go out of state in order to obtain their required surgical abortion and medical abortion training. Those who have a religious or moral objection may opt out. And then, yes, then there must be support. So there were also questions about like travel support and housing support and things like that. And those questions were answered satisfactorily. Thankfully, we haven't had to enact that plan. Our residents are still getting excellent exposure to abortion care here in our own state. But should the legal landscape change, we have a plan. Some folks may have seen this come up in the Washington Post relatively recently within the last couple of weeks. So this was a study that was published that showed that states with an abortion ban have seen a drop in residency applicants. So OBGYN resident applicants fell by about 5% nationally, but 10 to 11% in states with abortion bans. There have been several changes in residency application processes, but this is certainly, and so that drop can't be attributed solely to abortion bans, but it is certainly a concerning trend. And I think even more than that, we're very concerned about recruitment and retention of qualified candidates. The moral injury is real when you are unable to provide evidence-based healthcare for patients who need it, when you know that it's the right thing to do, and people do not want to practice in an environment like that. The other thing that I wanted to highlight is that this is not just OBGYN. So this was a study that was published a little bit longer ago. That wasn't just OBGYN residents, that was trainees broadly in all specialties. So this was a survey of more than 2,000 current and future physicians that was done on social media. So, take what you will about the respondents to that. But they found that most, over 80%, would prefer to work or train in states with preserved abortion access. More than 3/4 would not even apply to states with legal consequences for providing abortion care. So qualified candidates aren't even going to consider working or training in more than half of US states, because that's how many states have these restrictions and these consequences for physicians who practice abortion care. And that is not only for their patients, but also for their families. So they don't want to move their families to a place where their loved one could have a complication in pregnancy and not be able to access the full spectrum of reproductive health care. So now we are moving on to the effects of abortion bans. So this is specifically for Indiana. This We Count resource is a really cool thing that the Society of Family Planning created. It's a time-limited reporting effort that aims to capture the shifts in abortion volume by state by month following Dobbs. So on the screen, it shows the change in number of abortions between April of 2022 and December of 2022 in Indiana. And you will note that even though abortion was legal, that abortions went down by 41% during that time period. And so although it remains legal, it's still decreasing, like numbers are still decreasing. And the reasons for that aren't fully understood. A lot of it probably has to do with the fact that this is super confusing, and the lay public is going to have a really hard time understanding what is legal, where it is legal, how long is it legal, and am I going to get in trouble for even seeking an abortion in this state? So there was a really good article in the Capitol Chronicle a while ago in which a local abortion provider and former faculty member here, Katie McHugh, talked a lot about that, and how there are, they will get a lot of calls at the abortion clinic where she works for patients saying like, well, can you give me a referral out of state? And they say, yes, but you can also come here because we do still provide this service. Furthermore, the Indiana General Assembly has enacted over 50 abortion restrictive laws over the last decade, and so that isn't clarifying anything for anybody either.
All right, so there are some other weird things going on. The Biden administration, as you guys may or may not be aware, is a little more liberal leaning than our current Indiana administration. So they've taken some different interpretations. They control federal law. So I'm going to talk quickly about two federal laws. EMTALA is the one that says if someone presents to an emergency room, I need to provide you with a medical screening exam and stabilizing treatment to the extent possible by the hospital. And then the next one we'll talk about is the HIPAA privacy law. But following Dobbs, the Health and Human Services, the federal agency, sent out some guidance and said, hey, EMTALA requires that if a pregnant patient presents, an abortion is the treatment that they need to treat that medical emergency, notwithstanding state law, you need to provide that abortion under federal law. Well, the state of Texas quickly disagreed, and they sued, and the Texas judge agreed and said, you know what, we don't think that federal law prevents the application of our Texas law because there's an exception for emergencies. So currently that law is stayed in the state of Texas. Not to be outdone, the Department of Health and Human Services sued the state of, I'm gonna go with Idaho, to block the enforcement of their law. And in Idaho, the federal government, Department of Health and Human Services, won, and the Idaho law was prevented from going into effect to prevent emergency abortions required by EMTALA. So we are in this state of flux. Just recently, two hospitals, one in Kansas and one in Missouri, were cited by CMS when a patient who is experiencing a medical emergency presented for an abortion. She was turned away and ultimately had to travel to Illinois. So both of those have been cited by CMS. They haven't published any fines or anything else. In the state of Indiana, one of the frequently asked questions that's available on the resources that Dr. Rouse showed you, in the state of Indiana, any sort of mental health condition or threat to inflict self-harm is not considered a medical emergency. However, under EMTALA, they are very clear that psychiatric issues do qualify as medical emergencies. So one of the frequently asked questions there does address the question of what if a patient presents to a hospital claiming to commit suicide if they can't get an abortion. We had to choose between a rock and a hard place on that one. We ultimately decided on if the ban were in effect, that we would recommend transfer to another state. And we would take our chances with CMS coming in and citing us for that. But again, that guidance is located in our frequently asked questions. On HIPAA and patient privacy, again, following Dobbs, the Biden administration said, we're very concerned about the disclosure of information related to reproductive health. I'd like my administration to do more. They put out some guidance reminding everybody of their obligations and reminding protected covered entities that production in certain situations is optional, not mandated. They've now gone a step further and they've put this proposed rule out here that would require additional steps if a government agency is attempting to get medical records related to reproductive health care. And in certain situations, you actually can't get the records if it's related to a proceeding to enforce like an abortion ban or a criminal penalty. This is a proposed rule. In the resources, you will see that I've linked this. You guys cannot submit comments in your capacity as an IU health employee, but you are welcome to submit your comments on this in your capacity as individual physicians. This is an opportunity for you guys to participate in the democratic process. And again, that link is at the end. The last one, and again, this is all like happened within a year. It's amazing. The last one relates to mifepristone, which is the first part of a two-drug regimen. Yeah, first part of a two-drug regimen to induce an abortion, generally used prior to 10 weeks last menstrual period. And in this case, a group of individual physicians and anti-abortion activists filed in the Northern District of Texas, which is known to be a pretty conservative district. And they claimed that the FDA approval in 2000 was not appropriate. And the judge agreed with them and said, I'm essentially going to overturn that approval, with the effect that mifepristone would no longer be available to be marketed in the United States. Recognizing the import of that decision, he put a 7-day stay on that taking effect to allow the administration 7 days to go to the Court of Appeals and get a different opinion. Sure enough, they did. The Court of Appeals, in a very long and convoluted opinion that they were literally required to write within 48 hours, said, yeah, we don't agree entirely with the district court, but we're not willing to unroll it entirely. We think that we go back to 2016. And in 2016, MIFI was approved up to, do I have 7 weeks? Up to 7 weeks. And then there were also some restrictions about who could prescribe, the level at which you could prescribe. So they sort of rolled it back to 2016 mifepristone approval. Again, there was an immediate appeal to the Supreme Court, which stayed the original rollback while they considered it. And then just on the 21st, the Supreme Court said, you know what, we are going back to the way things were before April 7th. But we're only doing that until the Fifth Circuit has the opportunity to hear this case in its entirety. Oral argument in that case is scheduled for the Fifth Circuit. As you can imagine, there are a variety of arguments why that Northern District, Texas opinion was wrong that have to do with whether the claim, you can even bring a claim for something that happened in 2000, if the FDA process in itself was flawed, was the right evidence considered. So it will be very interesting to see what happens there, but that's ongoing. Again, we will provide guidance once the outcome comes out following that oral argument. If we were to go back to 2016, so we're at the 7 weeks, providers are allowed to use a drug off-label, And the Indiana statute on abortion-inducing drugs specifically includes off-label use of drugs. So our position would be that you could continue to use mifepristone if available off-label within the standard of care according to your medical judgment.
And then just to end our talk, thinking about the sort of longer term implications of these types of laws, abortion access and abortion bans affect everything. And I think one misconception that folks have had over decades is that this is a siloed part of care that, you know, is specific to one particular patient population and provider population, and it is not true. It affects everything. And we're starting to see that in other states. This is specific to Idaho, where there are reports that are consistently coming out about providers that are fleeing the state because of their truly draconian anti-abortion legislation. That is a total ban that has really severe penalties for physician. There's a trafficking law. It's crazy. This survey came out at the beginning of March that showed that half of practicing OBGYN physicians are considering relocating out of Idaho. 3 of the, I think maybe 4 or 5 MFM physicians have left Idaho, which creates a serious access and safety problem for the pregnant people of that state. And then it's not just OB, family medicine, other physicians, recruitment of new physicians has been incredibly difficult in this restrictive environment. And so moving forward for our own state, thinking about how this is going to impact our practice and our patients is something of which we are acutely aware. And we'll take questions.
Hi, we will pass around the mic in the room here in a moment, but there's one question online. The numbers that you mentioned regarding the number of decreased abortions in the state of Indiana, are those numbers procedural abortions only, or do those also include pill or male medication assisted abortions?
Those are all abortion procedures, not just surgical.
Thank you very much. Very informative. I was wondering, for the first slide that Dr. Rouse shared, that's a who's who of, all of our IU health leaders. With the amount of work and the level of expertise that all went into that preparation and planning, have other health systems reached out to us and everything that we've done and maybe not had to do yet, but obviously a lot of work has gone into that?
No. Yes.
Well, I was going to say, maybe I'll defer to you because I think you were thinking about a paper or something on the work.
Yeah, there are other health systems across Indiana that have replicated what we've done.
I was just also be curious across the country, not only locally, but
All I know is locally.
I think that in Tennessee, like maybe at Vanderbilt, they had a similar type of a response team because their total ban was also came into effect. So I think that they did that too. That's one that I am aware of. I'm sure there are others.
And I would just add, it was extraordinarily helpful. As you probably know, like once the law was passed and going into effect, there was a lot of rumor and innuendo about what was going to happen, what it was going to mean. And it was essential to be able to speak with one voice across the system when it came to this law.
Lisa and Carrie, that was absolutely outstanding. I have a specific question about the injunction that's in place in the state of Indiana, specific to why do you have an opinion or an impression as to why the Indiana Supreme Court accept or, was willing to hear the first case that was asked to be moved directly to them, but then the second case, they declined to hear that.
Yeah, I don't have an opinion. I can't read the tea leaves on that one. I would throw it out to any of the other attorneys in the room. Any insight into that? No. Yeah, I don't know what that means. Maybe that's their quota for the year.
We have a couple questions online. One is in regard to travel restrictions for abortion care. Is there any talk about that within the state of Indiana?
So that hasn't hit the legislative agenda yet. And I think the question is referring to legislation similar to what they have in Texas, which provides for a civil cause of action for anyone who aids or abets in the provision of abortion. So if you drove someone out of state, if you bought them a plane ticket, if it's a very broad statute. I haven't heard anything like that proceeding in Indiana.
I will say there is a lot of overlap in the strategy in anti-abortion and anti-gender affirming care. And the SB, what is it, 480? It's like they took the things that they were not successful with the abortion ban and applied it to 480. And I think that there is a like you can't, you can't refer for gender affirming care, or there's some restriction that involves travel with that was not included in the abortion ban.
Yeah, on gender affirming care, they did include the aiding and abetting language, which the ACLU, the Attorney General, and then our own internal guidance does read as a prohibition on referrals for what would be considered a gender transition procedure, even in states where that's legal. And just since we're referencing it, we are putting together a similar implementation team on State Enrolled Act 480 to try and get consistency of information out there related to that also. We're hoping that one gets enjoined similarly.
Another question from online, particularly about the We Count project and some of that data. Is there a way that the data around people who are receiving abortion medications outside of the healthcare system or outside of the state are being tracked within that system?
I don't think that We Count data includes self-managed abortion, if that's what that question is about. I think it is provision of abortion care from a healthcare provider. And self-managed abortion is very difficult to track and get data about.
But yeah, I do wonder if the concern has something to do with the security of data around your protected health information for people who do seek reproductive health care that might otherwise be banned by this law. Again, if that HIPAA proposed rule goes into effect, that does provide some additional protections. I included the link to that if you guys wanted to see it there too. I know there's been a lot of talk also about, it's a wild world, talk about period tracking software and a number of other things. So just very, very interesting what data you put out there about yourself and who has access to it. Are there any other questions? I'm amazed if there are no other questions.
Right, a couple more online, and then we'll go here in the room. One question, do you think abortion laws may affect decisions around peri-viable infants in the future, and what does that look like?
Yeah, it is all a continuum, it is all a spectrum, and it is all related. At the limits of viability, so like really, really early in gestation, 20 years ago, and then again resurging within the last couple of years, there's been legislation about born alive infants with a concern about, requirements for resuscitation and things of that nature. So that stuff is already out there and we are actively dealing with it. So the answer is yes. I think it all is, it's not just abortion. It is definitely abortion. It is not just abortion though.
Yeah, I'll add, and that's a great question for our ethics person too. I mean, the intersection of born alive care requirements and the, I guess, the lack of an obligation, right, to provide care that is medically futile. Those things, how they intersect and what the right answer is for a born alive infant who you know is ultimately going to die. So.
I had a question about sort of criminalizing doctors doing their job, especially in light of the nurse in Tennessee, and like what sort of criminality have we seen coming out of like Texas? And because it's hard to know what's real and what's just sort of like smoke in the water.
Yeah, in terms of actual criminal prosecutions coming out of any of these abortion bans, I honestly don't know of a single one. I do know of some civil actions under that aiding and abetting one in Texas. But I don't know, and certainly I don't know of any criminal proceedings here.
Hi, okay. I'm a chaplain. I'm also going into the School of Medicine next year and thinking about specializing in OB. So my question is about moral distress among caregivers. Can you speak more about that, please, so that we can understand it better?
I would say it is significant and it is ongoing and it is growing. We try to support each other and ourselves as best we can. Within the OBGYN residency, there is a mandatory values clarification that happens when interns first come in to sort of help them identify things that make them uncomfortable, things they have questions about, just trying to, clarify their own values and opinions about the procedures and the care that they are going to be providing to their patients. I don't have a great answer for you. It is really hard. I know more about the law than I thought I would ever have to, and I love the law. But having it have to be part of literally my everyday life is hard. It is hard to think about this stuff all the time.
I would, just on the other side of that too, there is an Indiana law that if you have an opposition to abortion, you can't be compelled to provide abortion care in the state of Indiana. IU Health has a policy for how you would opt out. And it's important in that policy that you sort of declare your opposition well in advance of being put in a situation where you would have to provide that care.
Okay, I have a question for you probably, Lisa. But so the assumption has been post-Dobbs that the abortion question is essentially completely resolved at the federal level. And so everything is returned to the states. But the way I read Dobbs, it really has just changed the standard of review for abortion legislation that happens in the states. And so it becomes the lower test, right? The lowest test. So I guess my question is, where is the attempt to attack these laws even under that rational basis review? Because a lot of them, for example, that abortions have to be provided in a hospital seem to have no reasonable relationship to literally anything. And so has there been, are people talking about looking at these laws almost kind of line by line and saying, nope, we're knocking that out, we're knocking that out, we're knocking that out, to the point where you're essentially returned to where you were because none of the restrictions really make any sense?
Rational relationship is a low bar. Whole Woman's Health up in South Bend actually challenged the Indiana statute, claiming that the hospital licensure requirement wasn't rationally related, and that failed. So it's a pretty low bar.
Where did it fail? Like in the district courts?
Yeah, so they determined that it was rationally related to the requirements. Same thing, I think, with some of the telehealth prescribing. right? So they looked at the same bar. I actually think that went up to the Seventh Circuit Appellate Court, but I can follow up with you on that as well.
I'm kind of interested in it.
Yeah, yeah.
Me again. As you walked through kind of the details of the ban, one of the things that we talk about in ethics sometimes is feasibility of implementation. And I think about, uh, Amy Martin in the back always says that which is not feasible is not ethically required. And I think a little bit about the implications of these bans. And as far as I know, there was not, in conjunction with the legislation to ban abortion, concurrent infrastructure to support the patients or children and babies that would be born as a result, many of which, Carrie, you spoke to, would have significant healthcare needs. And I wondered, are you able to speak to whether or not there was active discourse about added pieces of legislation to ensure adequate infrastructure and resources to support these lives that that people are insisting now exist?
Yeah, they actually did allocate some money at the same time when they passed this legislation in August. It's my recollection that the bulk of that money went towards religious affiliated conservative anti-abortion organizations.
Correct.
But the original, so my answer is I don't know on that, but I know in conjunction with this one, they did allocate some additional funds to other organizations, but I don't know about the tax credit.
Okay, sorry.
You can just come up.
Hi, so what I said was SB1 was the abortion restrictions or abortion ban, but SB2 was also passed. And I'm not a lawyer, I'm a nurse, and I can only give you just a little bit, but I believe that in SB2, the child tax credit was doubled for all children, not just children that could be aborted or may have special needs or whatever. And that there was also a provision for adoption and fostering that kind of went under the radar and unnoticed. So
Yeah, I think SEA2 was a little bit of a mixed bag because it did, like Lisa was saying, provide a pretty significant amount of money to the so-called pregnancy resource centers or crisis pregnancy centers, which are unlicensed places that people can go for, that people do go for supports and things like that, but do provide medical care and assessment of pregnancy without actually being a licensed like medical facility. So that part of it was remains pretty problematic.
It's interesting that I run into this when you're completing abortions and when baby is born alive and expected to pass a meal. That baby born alive gets a social security number and they get child tax credit because they're born alive. And I think that is so interesting looking at our laws compared to a stillborn who is not.
So my question is like kind of related to the prior one. So taking more of like a justice lens, as we know, like various social determinants of health are going to impact our patient population. And in particular with this, these determinants are going to create disparities even wider with abortion bans. So how has your guys' like implementation for that patient care taken these extra like social determinants of health into your consideration when considering care for your patients?
So abortion bans are always going to affect disproportionately the people who are always on the wrong side of the disparities. And, you know, in our care of OBGYN patients and people who are seeking abortion, we try to be aware of that. And there's nothing specific in the implementation team that necessarily spoke to those disparities, but you know, the locations of care and how we try to get people into care. We provide abortion care at Eskenazi and then also at IU Health. So that is part of it, but I don't have a great answer for you. You know, it is hard.
I think, well, one thing that we did, right, so if you think about the location following the ban where you can provide, I mean, it will be just hospitals and largely IU Health and Eskenazi and all of the various different abortion clinics out there, is that we're providing very clear referral pathways for patients to try and make sure they know where to go. Social work always has budgets for transportation and different things, so we're trying to get that out there.
Okay, we have a question from our online viewers who have said, it is a member of the SB 480 response team asking what challenges you have faced in the implementation of the response team.
The rapid response team?
Yes.
I think initially people didn't know what it was or how to get a hold of it. So I think marketing that resource as broadly as possible is really important. I think the uptake of the rapid response team has been relatively low, obviously, in the absence of the abortion ban. Honestly, it's mostly been me calling Lisa about questions. And I am the clinical part of the rapid response team. But I would say that mostly just making sure that people are aware of that resource is the most important part of it.
And then I think also you need to have sort of clear pathways for different level of emergent questions, right? So our rapid response team is if you had a patient in front of you that needed assistance right away, right? Notwithstanding that, we would get questions about, I've got a theoretical question about a hypothetical situation that might never happen. And, you know, that can go a different path than hitting your diagnosis. Yeah.
Could you talk a little bit about IU Health's compliance with the new laws as they are coming about, particularly the protections that you provide to providers, or if providers may not want to follow the recommendations or some of the legal aspects that have come about?
Yeah, so we have a frequently asked question on this, and I'm going to try and answer it pretty simply. Like, if you access our resources and you follow our policies, you are going to be covered. We are going to protect you. We are going to use our values to do that. However, if you knowingly do something that is outside of the guidance that we give, you will also be outside the protections of your insurance coverage, most likely. So pretty clear. If you follow the guidance that we give you, we're going to protect you. If you're outside of it, you're on your own.
Right. So one shout out that we want to give here is Ann Hannon has asked us to share that with the labor and delivery staff, there has been an intention to give unit-based ethics conversations to alleviate some moral distress among that team because of some of the challenging aspects of this. So if you have any questions about that, please reach out to Ann Hannon at ahannon@iuhealth.org. Other than that, thank you both for your time and have a great rest of your day.